Thank you very much. I'd like to start out by thanking Rodrigo and the council for inviting me here today. It's my first trip to Brazil. It's very much a pleasure and an honor to be here to talk to you a little bit about a topic that I'm very passionate about, that being return to sport after ACL reconstruction. And really we want to ask the question, how objective is that decision? When we decide when someone's ready to return to sport, when we have to make that decision, how objective is that decision that we make? So my objectives for the next half hour are to review the current tools that we use to assess readiness to return to sport after ACL reconstruction. And we want to critically look at that. We'll look at the literature and think about what some of the strengths and weaknesses are around current return to sport criteria. And then we want to take a step further and discuss means to return to sport and how we can improve that evaluation, how we can try to take that to the next level, utilizing some of the current literature and some of the current research that we've done in our lab. So when you ask yourself the question, when is my athlete ready to return to sport? In my mind, that really boils down into two questions. One being, when is it safe? When will the athlete return with the minimal opportunity or the minimal chance to get hurt again? And the second is, what are the functional demands of that sport? When our athlete returns to sport, what are we specifically asking them to return to, and are they able to actually do that? Then when we start to talk about the question of safety, the one that most frequently comes up is when we talk about long-term safety, and that being the risk of osteoarthritis later in life. And Lomander and others since, in 2004, have done very nice studies to demonstrate the very high incidence of osteoarthritis after ACL injury. Specifically in Lomander's study, they looked at 103 female soccer players and followed them up for 12 years. And what they found was that after 12 years, over 51% of those athletes who had suffered an ACL injury had radiographic evidence of osteoarthritis, while only their contralateral limbs, only 8% had that signs of arthritis. Interestingly, in this cohort, Lomander split the cohort into those who had had ACL reconstruction and returned to sport, and those that had elected to not have ACL reconstructed and continue to participate. And what these authors found was that both groups went on to have osteoarthritis. So again, the old adage that we have ACL reconstruction to hopefully prevent future osteoarthritis doesn't seem to be panning out in this population. A second question, which is probably of keen interest to a lot of our young patients, is what's the incidence of a second anterior cruciate ligament after ACL reconstruction? And the reality of it is athletes with a prior ACL injury are at much greater risk for future ACL injury. Rick Wright, who published a very nice study in 2007, summarized data from the MOON group, which is the Multi-Center Orthopedic Outcome Network. And in this multi-center study, what they noted was that 6% of their patients, or 1 in 17, who had an ACL injury, had ACL reconstruction and went back to return to sport, actually suffered a second ACL injury. Half of those subjects, or about 3%, retore the same graft, and the other half tore their contralateral ACL. More alarming, in 2007, Pinkowski published a 10-year outcome study, and in this study, he noted that 27% of his athletes, or 1 in 3.7, suffered a second ACL injury in the 10 years following ACL reconstruction. So when we talk about safety, this is a significant concern. Will my athlete go back to sports and have a second ACL injury? Well, let's take a step further and talk a little bit about the functional demands of the sports. And whenever we think about what makes a great athlete, certain variables or certain things come to mind, such as strength, power, agility, endurance, balance, and postural control. And all of these are things that we incorporate into our decision when we try to evaluate if someone's a good athlete, but also when we evaluate the ability of someone's readiness to return to sport. When we ask that question after injury, though, we also ask questions related to mechanical stability and functional stability as well. So let's talk a little bit about what criteria is currently used and currently summarized in the literature as far as making a decision about return to sport. And if we look back to the literature, in 2004, Kavis published a very nice article, a systematic review, which reviewed 34 articles over a 5-year span between 1998 and 2003. And in this publication, she tried to summarize what the current criteria was to return to sport. And if we looked at those 34 publications that she utilized in her systematic review, what we saw was that there was dramatic inconsistencies in the published literature. 13 out of the 34 publications utilized some type of isokinetic strength assessment. 25 out of 34 utilized jump testing. 14 out of 34 used some type of clinical criteria such as range of motion or strength. And 4 out of 34, or over 10% of the publications, had no assessment of strength or performance in their decision-making process to return to sport. So let's talk a little bit about what was probably used the most frequently today in clinics across the world. And I believe these are the 4 variables that the majority of clinicians use, which is supported by Kavis data. That being time from surgery, strength, knee laxity, and functional performance testing. Now we'll look at these individually and see where some of these weaknesses lie. Let's talk first about time from return to surgery, or essentially telling our patients that at a certain point in time you'll be ready to return to sport, no matter what type of objective findings we have. And Chris Harner in 2001 published a study which was essentially a summary of a questionnaire that he put out to surgeons and physical therapists alike who were considered a panel of experts, and he asked them when they let their patients return to sport after ACL reconstruction. And what we noticed is a tremendous amount of variability, and these being his findings, that some authors let their patients return to running, jumping, and light sports very early on, 1 to 3 months after surgery, while others made them wait to 9 to 12 months after surgery. So again, if we use arbitrary numbers related to the time since their reconstruction, again, we see dramatic inconsistencies in the literature. And again, if we looked at Kavith's data, she very nicely summarized this almost bell-shaped curve, where about 9 to 10% of the publications suggested that their patients could return to sport in 3 to 4 months, whereas probably about a third, or 32%, said it would take about 6 months, and then about 10% said 9 months or greater. So what's the next variable that the majority of us use? And I would argue that strength and muscle performance is the key variable. Now, how do we assess strength and performance? We can do it on a very simplistic manner, such as manual muscle testing. It's one that requires very little equipment. It can be done in any setting, whether it's on the field or in the clinic. But unfortunately, current data suggests that manual muscle testing is not a very reliable predictor of someone's strength. Kevin Welk published a very nice study in the 90s, which suggested that after arthroscopic surgery, patients had very normal manual muscle testing of 5 out of 5 with knee extension and flexion. However, when they went on to do a much more subjective or more objective test, such as an isokinetic assessment, what we found was that over 50 to 75% of those athletes still had deficits in their isokinetic knee extension and flexion. As a result, we see that manual muscle testing is probably not the most objective tool, although we can do it in any clinic. So we can move on to isokinetic strength testing. Unfortunately, it's a very expensive test, but one that's more objective and certainly has its limitations as well, such as isolating only one muscle group and not giving us a good functional profile of a lower extremity strength, which takes us to functional performance testing, which is, Rodrigo just outlined for us, is a very nice tool to assess lower extremity function. However, it too has its limitations. Well, what if we look only at strength? Because if we say, when we look at limb symmetry index of less than 10 to 15% difference side to side is a variable that we often use from a strength perspective. But studies by Matacola and Kobayashi have shown over the last 10 years that it may take 18 to 24 months after ACL reconstruction to attain this normal limb symmetry index, which in fact is much longer than any of us would suggest to return our athletes to return to sport. So what about mechanical stability? If we assess that mechanical stability after an ACL reconstruction, do we use that variable to make a determination of readiness to return to sport? When we look at stability, tools such as the Lockman exam, the KT 1000 or 2000, or the pivot shift exam are those which are frequently used in our clinic. However, we must ask the question, what is the relationship between this mechanical stability that we can very objectively assess and functional stability, or that giving way that the athlete may see as well? And studies by Coker and al. have very clearly shown that there's not a very good relationship between mechanical and functional instability, much to the Coper concept, which we just heard about. Min Coker actually, in 2004, in this study, noted when he tried to look at the relationship between these assessments of mechanical stability and other patient-reported outcome, noted that the only one test that seemed to have some relationship to things such as giving way, satisfaction with their outcome, difficulty with running and jumping was actually the pivot shift test, which actually, if we think about the role of the ACL, it's certainly it has triplanar responsibilities. It limits not only AP translation, which the Lockman exam assesses, but also looks at restricting motion in 3 planes. And if this is the case, really the pivot shift exam is the one exam that gives us some assessment of stability in 3 planes. And yet I would argue it's the one that we probably do the least frequently. Well, what about functional performance testing? Now, there's been many, many functional performance tests which have been designed in the literature, and the ones that are probably most frequently used are the ones described by Noyes et al. Many years ago, over 20 years ago, such as the single leg hop for distance, triple hop, crossover hop, and the single leg time hop. But the goal of any functional performance test, now whether it's one of these 4 or others which have been designed, is to try to mimic a functional activity to make a correlation for readiness to return to sport. Functional performance tests can be one of many, and here we see a very simple one, such as a single leg squat. Now, a single leg squat, we can simply measure the depth of knee flexion, or the amount of knee flexion that we see, but there's also other qualitative measures which typically we don't have the ability to assess in our current tools, such as the amount of trunk flexion she's utilizing, or her ability to maintain a balanced posture during this activity. Although a single leg squat can be a very simple but objective tool, it may actually not give us a full information of someone's readiness to return to activity. Here we see a single leg hop, and we just saw a nice video of this as well. But look at this young athlete and look at how she lands. With an athlete who has a more normal landing pattern, you would generally notice good knee flexion and the ability to absorb the forces of their body while they're landing. Well, look at her. As she lands, you see a very rigid posture, and in fact, one that's very dangerous if this athlete were to return to sport. It's suggesting that maybe she doesn't have sufficient lower extremity strength to control these eccentric muscle contractions and control her motion, and unfortunately may be at high risk for future injury. Well, here we see another example. Here we see a triple crossover hop, and this athlete, you notice, isn't able to stick her landing and has a lot of difficulty with both the takeoff and landing. So again, if we measure the distance that she jumps, and which is the way we typically assess functional performance testing, she may have similar distances hopped side to side. However, within that number, within that limb symmetry index, we may not be capturing the true essence of the quality of her movement. So some of the problems we've seen with functional performance testing, as been noted in the literature, is low sensitivity and specificity and issues with relationships to others' measures of impairments and disability. And what's been noted in the literature, and probably was most clearly defined by Kelly Fitzgerald in 2001, is because of these low correlations between hop testing and other self-reported measures, there's probably not one assessment tool that's adequate to determine someone's readiness to return to sport. And I think that's probably the most important point. Whenever we make a decision about someone's ability to return to sport, all of us would love to have one tool. To have one tool we could say, hey, if they do well on this test, that we'll be able to progress them safely back to sport and they'll be successful. But unfortunately, that one test doesn't exist and really speaks to the need for us to develop some type of functional profile. So if we look back to the article by Kvist, again we can notice huge variability in the literature over the criteria that we currently use to make a determination about return to sport. So now that begs the question, what are we missing? And I will look specifically at things such as patient-reported outcomes, balance and proprioception, postural control, and probably most importantly, looking at bilateral asymmetries, or the inability to balance forces side to side. So patient-reported outcomes, they've been described through our conference today, and they've been described in the literature for many years. And this is a really important tool that I think we need to utilize to have a better assessment of how our patients feel they're doing. Coker very nicely showed that there was not a good relationship between many of the tests that we utilize and, in fact, the outcomes that our patients have. So again, it's important for us to survey them and get a better appreciation of how they're doing day to day. Postural stability, and I'll speak to this in a moment, has been demonstrated to be a very important variable in not only separating those functional activities after ACL reconstruction versus a normal population, but also, as I'll speak to in a moment, has been shown to be predictive of future ACL injury. And finally, side-to-side differences, or bilateral symmetry with functional tasks, have been identified as a predictor of injury in a healthy population. And now some of the studies that I'll speak of in a moment have demonstrated that after ACL reconstruction, these athletes for many years after they've returned to activity still are unable to balance forces between their lower extremities, which we think can be a very high risk, create high risk for future injury. One of the first studies that started to talk about this was done by Neitzel et al. In 2002, and they looked at a very simple task. They were only interested in the ability to balance forces between limbs when you do a simple squatting task. So they looked at 3 groups after ACL reconstruction, one that was more acute, about 3 to 4 months after ACL reconstruction, one that was 6 to 9 months, and then a final group that was 12 to 15 months after ACL reconstruction. And what the authors noted was that after ACL reconstruction, only the group that was greater than a year out of surgery was able to balance forces with a simple squatting task. Obviously, we return our athletes to sports much sooner than a year after they have their ACL reconstruction. So apparently we're allowing our athletes to return to sport with these significant impairments still in place. That motivated us to look at a higher level task, because we asked that question. If someone can't even balance their forces with a simple squatting task, how would they do with something like a drop vertical jump, which is really a test that we do very frequently in our lab. And what we noted was that 2 years after ACL reconstructions, athletes were still unable to balance forces with a drop vertical jump task. So again, it begs the question, when are athletes able to demonstrate an equitable distribution of force when they do a task when we ask them to do such. And this brings us to our latest publication, which was published in AJSM last year in 2010. And we looked specifically at biomechanical measures during landing and postural stability and looked to see which one of these variables would actually predict which athletes went on to have a second ACL injury, whether it be their contralateral limb or a re-tear of their ipsilateral limb. So we asked that problem. We really asked ourselves, who was at risk? Because few studies have reported on risk factors for a second ACL injury. And in fact, many of the risk factors which have been identified are not ones that we would consider modifiable, such as they had a contact mechanism. We're very interested in trying to identify modifiable risk factors that would hopefully drive changes not only at the end stages of our rehab, but also in our decision making about returning to sport that would actually predict a second ACL injury. So the purpose of our study was to use a prospective case cohort design to identify predictors of second ACL injury after ACL reconstruction. Our theory, our hypothesis was that after primary ACL reconstruction, prospectively measured deficits in neuromuscular control and both the hip and knee and postural stability deficits would predict ACL injury. So we recruited a cohort of 56 subjects, 35 females and 21 males after ACL reconstruction who had injured their ACL, had ACL reconstruction, and been cleared to return to sport by both their physicians and their rehabilitation specialists. 25 of those subjects had a bone tendon bone graft, 27 had a hamstring graft, and 4 had allograft. You'll notice that we recruited subjects who were very young. They had a mean age of 16 years old, and the range was between 10 and 25 years old. The reason for that is we wanted to recruit a group which we considered high risk, and the reason for this group being high risk is generally they return to sport at a very high rate. The methods we utilized, all of our subjects, once they were cleared to return to sport, they came into our lab and underwent a full biomechanical screening, which included our drop vertical jump maneuver. They jumped off a 31-centimeter block, landed onto 2 force plates, and then executed a maximum effort vertical jump. And we were interested in the biomechanics during this landing phase of the jump, as we theorized that the majority of ACL injuries occur during this landing phase. In addition, we assessed postural stability using the Biodex stability system. Following their biomechanical analysis, the athletes were released to return to sport. During the 12 months following their testing, we tracked them on a regular basis, and we tracked them for athletic exposure and also the presence of any injury, specifically ACL injury. And during that 12 months time, 13 subjects, 11 who were female and 2 were male, sustained a second ACL injury. 10 of those injuries were contralateral injuries, and 3 were graft re-tears, so a very high rate of re-injury. From our data analysis and through the use of multivariate logistic regression, we were able to determine a statistical model which included 4 variables which would predict with high sensitivity and specificity which one of these athletes would go on to have a second ACL injury. Those 4 variables which we identified were hip rotation moment during the initial 10% of the landing phase, which had an odds ratio of 8.4, 2D frontal plane knee motion in landing, which had an odds ratio of 3.5, side-to-side difference in sagittal plane knee moment at initial contact, which had an odds ratio of 3.3, and deficits in postural stability, which had an odds ratio of 2.3. And I'm going to talk about each of these variables individually over the next few slides. So hip rotation moment. So net hip rotation moment was defined. So if we look at a graph of the landing phase, so this point here is right when the athlete hit the ground, and this point here is when the athlete took off. So this is the landing phase. And we were interested in the first 10% of the landing phase. And what we noted was the red line, which represents the group which went on to have a second ACL injury, actually had an internal rotation moment. So when they hit the ground for the first 10% of the landing, they were actively internally rotating their femur, which would bring them into more of a valgus knee position. Conversely, the group that did not go on to have a second ACL injury actually had a hip external rotation moment during that first 10% of the landing phase. The second predictor was frontal plane knee motion, or dynamic knee valgus, which has been discussed in the literature extensively with a healthy population as a predictor of future ACL injury. And again, we see that in this population as well. The third variable was side-to-side differences in sagittal plane moment. So essentially what we looked at is the point of initial contact. Right when the athletes hit the ground, we looked at the side-to-side difference, or the ability to equitably distribute forces in a sagittal plane at the moment they hit the ground. And you'll notice by this graph here that our young, healthy athletes, or those that did not go on to have a second ACL injury, have very similar net or sagittal plane moments at initial contact. Conversely, we see significant differences between the involved and uninvolved limb, or big side-to-side differences. In other words, the athlete isn't balancing those forces. And we see that in this video here. If you look at when this young athlete jumps off the box, you'll notice that she leads with her left leg. Conversely, we're asking that athlete to jump off the box with both feet at the same time. However, she's leading with that left leg, demonstrating she's probably favoring that leg a little bit. Here as well, when you watch her land and take off, you'll notice that she's leaning a little bit to the right. Again, she's favoring one leg versus the other. And we're looking at that point of initial contact, and we saw those significant side-to-side differences, which went on to predict a second injury. Another higher level activity, which we often use, is a tuck jump. And you can appreciate when this young athlete does this task, how much valgus she has in her knees, both actively and passively, during the takeoff and the landing. And again, very predictors, we think, of future ACL injury. And the last task was postural stability. So we assessed the athlete's ability to maintain a level stance over a 20-second period, and what we found that those who had the greatest difficulty doing that had a higher risk of future ACL injury. So if we summarize those variables and we look at those variables clustered together, we see that, that there's an area under of ROC curve of 0.945. So essentially, those four variables, when put together, can predict with high sensitivity of 0.92 and high specificity of 0.88 of a second ACL injury. Interestingly, when we look at the one variable, what was the greatest predictor, and if you remember back, it's that hip internal rotation moment during that first 10% of landing. If we only look at that one variable in isolation, it too can predict second ACL injury with sensitivity of 0.77 and specificity of 0.81. So if we summarize these findings of our study, we see that the predictors of second ACL injury were hip rotation moment at the onset of landing, 2D frontal plane knee motion or increased valgus, side-to-side differences in sagittal plane knee moment, and deficits in postural stability. Well, let's talk a little bit about these variables, because I think they're important for us to think of, not only at the end stages of rehab, but as we start to think of better ways to evaluate someone's readiness to return to sport. So the concept of dynamic valgus has been in the literature for several years now, and it's been defined as the combination of hip adduction, hip internal rotation, knee flexion, knee abduction, and tibial rotation. And that's been clearly described by many authors over the last 8 to 10 years. But when we look at the result of dynamic valgus, it's interesting to note that in cadaveric studies, which was identified by Markov in '95, there's an increased strain on the ACL in this dynamic valgus position. Moving a step further, Hewitt in 2005 prospectively identified this valgus knee position as a predictor of future ACL injury in young, healthy athletes. So we're seeing that valgus position puts strain on the cadaveric ligament in a healthy population and predicts ACL injury. And now, after ACL reconstruction, we're continuing to see that it predicts second ACL injury. Now let's look at the strongest predictor being that hip rotation moment. So if we look at the hip rotation moment at the initial 10% of landing, again, we noticed that it was the strongest predictor of second injury. And this is really interesting considering the recent literature which has discussed the evidence that hip external rotation and hip extensor moments contribute to controlling hip internal rotation in an athletic population. So if we think about that dynamic valgus posture, if we can work on, from a clinical applicability standpoint, if we can target our rehabilitation to work on our hip extensors and our hip external rotators early on in rehab and later in rehab, it may give us the opportunity to improve outcomes and decrease the risk of second ACL injury after ACL reconstruction. Well, what about the side-to-side differences in sagittal knee moment? Again, Hewitt in 2005, when he looked at a population of healthy female athletes, identified side-to-side differences in ACL, or in side-to-side difference in loading pattern as a predictor of future injury in healthy populations. Again, and we looked at ACL reconstructed population, both in Neitzel's work and in our work from 2007, we noticed that many of our athletes had difficulty balancing their loading patterns, whether it be with a simple squatting task or a higher level task such as a drop vertical jump. Now, this data is suggesting that inability to balance forces may be increasing our risk for future ACL injury. Deficits in postural stability have been defined for many years, and in fact, probably the most simplistic definition of postural stability is a means to assess your ability to maintain your center of mass within your base of support. And the recent evidence by Zaslak and others has noted that the migration of the trunk outside of the base of the support, or the inability to maintain the position of your trunk, actually can predict future ACL injury as well. And now we're seeing similar variables predicting second ACL injury after ACL reconstruction. So where should we go from here? What are our future directions? Well, the identification of these high-risk variables that predict future ACL injuries they're really only the first step in making improvements in our outcomes after ACL reconstruction. So, and our ability to develop and test more specific and efficacious interventions are really going to be the key to bring us to the next level. And hopefully we can do that by creating more targeted interventions to try to address some of these impairments and some of these deficits, which we've now identified as potentially high risk for future ACL injury. So to conclude some of our thoughts this morning on return to sport. We know that the incidence of a second ACL injury after ACL reconstruction is high in a young and active population. And that's, as we know, it's the population that most frequently wants to return to sport. These potential risk factors, we've prospectively identified some of that through this work, but certainly future work needs to look at other variables to determine if they too may be predictors of future ACL injury. And our future studies really need to investigate this more rigorously, and not only to target developing better criteria to return someone to sport, but also creating better end-stage rehabilitation to try to target these interventions so our athletes have a reduced risk of second ACL injury. So just as a final note, and we talk about what some of these interventions and what a better criteria to return to sport might be, I would reference you to an article we published in JOSPT in 2006 entitled The Rehabilitation After ACL Reconstruction, Criteria-Based Progression Through the Return to Sport Phase. And in this publication, it's a clinical commentary. So essentially, we were charged with the opportunity to investigate the literature, try to pull together the best evidence, but also had the opportunity to include some of our own anecdotal evidence. And with that, what we thought was, and what our goal was not to create the gold standard. It wasn't to create the criteria-driven progression that could be unmatched by anything else. And in fact, really our goal was to stimulate discussion in the healthcare community about how we can develop better criteria to return someone to sport on a much more reliable and valid level. So I'll only make one summary point related to this article because we're running short on time. But I think one of the biggest limitations of this study, because when we look at our criteria approach to make a decision of to return someone to sport, it was very technically driven. We use a motion analysis system, we use force plates, we use many different tools which are typically not seen in every physical therapy clinic. And as a result, what we need to do is in the future look to tools which could be done in any clinic, such as hot testing or some other type of assessment that would give us a much clearer picture of someone's readiness to return to sport and give us very more reliable and valid data. So to summarize, our current methods, as we mentioned, to return to sport, they include subjective reports. We certainly oftentimes look at laxity. Many times we use time. We look at muscle performance. Many of these variables are what oftentimes all the clinicians throughout our nation are utilizing and through our countries are utilizing to make a decision about readiness to return to sport. But as we've hopefully seen over the last half hour, some of the critical variables which we think can better predict someone's readiness to return to sport, we're not evaluating them at all, and we're not using them as the criteria to make a decision about someone's readiness to return to sport. So future research truly needs to explore this more closely so we can better define someone's readiness to return to sport. The next frontier, as we mentioned, looking at more effective ways to analyze someone's ability to return to sport and determine if they're going to have a poor outcome, determine what cluster of variables could in fact predict a poor outcome, as we saw in this last study. We want to take that a step further and try to modify our current criteria that we use to better align with some of these variables to make a determination of readiness to return to sport. And then finally, we need to modify the end stages of rehabilitation. So our targeted interventions will be just that, targeted towards ensuring that those variables which are most predictive of someone's readiness or of a poor outcome are being addressed at the end stage of rehabilitation. So with that, I thank you very much for your attention.